Hi everybody, I'm Jan Holding and I'm one of the principals in public health in Warrington. I'm not actually the lead for neighbourhood working in Warrington. That's a lady called Jane Critchley who unfortunately couldn't be here today, so I drew the short straw, as it were, to come along today to talk to you about Stu. Stronger Together is a concept of neighbourhood working, and it started in Warrington in the most deprived aspects of the town. It started in 2006, which seems like an awful long time ago, 7 years ago, which it is actually. That's a little bit of what Warrington looks like. So Warrington is a quite unusual town in that it's an old industrial town, and if you look at it, it's got some of our wards are in the most deprived 10% nationally, but some of them are in the most affluent. So we have very rich areas sat next to very poor areas. The poor areas are the wards that are in the inner town. So as the town grew, it grew outwards and became richer. So that's how the town looks today. And Stu, as I'll call it throughout this project, was centred on those most 10% deprived wards. Those wards with the biggest problems, as it were. We're all familiar with that. That is what affects our life, our well-being, our health, our outcomes. And it's everything that we go through from the minute we're born, the school we go to, the food we eat, our parents, everything that affects us and our life chances. And that's where Stronger Together came from. It was about trying to improve all of those aspects to give those people the best possible chance of living well. What is quite stark in Warrington is the inequalities and the life expectancy between the people who live there. I live in Grappenhall and I'm probably going to live 11 years or 9 years longer than somebody who lives 2 or 3 miles down the road. And that is quite stark, and that is what we wanted to reduce in public health. So we started in 2006, and the idea was to shift the cultures and mindsets of the public sector. In some ways, the public sector had it hadn't turned its back on the more deprived areas, but there was areas in Warrington that didn't see any public services. They were deserts. And what we wanted to do was put a focus on those areas, those 10%. So, as I say there, the end point would have been community budgets, so giving the people the power to take control of their own money and their own public services. Shift the attitudes and expectations of the people living there, to get them to think about what is delivered to them, how they use it, what their expectations and aspirations are for their lives, and for the lives of their children that they were bringing up. What do they want for those kids? And openly recognise the life inequalities that existed in the town. That was a big issue. If you're sat in one of our leafy suburbs, you don't want to really know that 6 miles down the road there's people living a lot less years than you because of X, Y and Z. And we wanted to be very explicit about that, especially in public health. This is a little bit about the governance of Stronger Together. 7 years ago, we reported to the local strategic partnership. We had a strategic set of delivery partners. They were the PCT, health services, police, etc., etc. And then here is the governance of Stronger Together. So we had a board, and that board was made up of 1/3 residents, 1/3 elected members, and 1/3 partners. So strategic partners that could make decisions. Underneath that was a set of subgroups that spanned the issues within those areas. So access to skills, access to good jobs, health services, education. There's a whole range of them. There's about 6 or 7, and those themes came out of all the questions and consultation that Stronger Together did. So that just talks about the makeup of the boards and who was involved in the discussion. It was quite difficult in the beginning to get people to the table to talk about this, because fundamentally it meant a shift of their resources, which isn't always easy. So we worked quite hard on getting people to engage in the debate. In terms of communication and engagement, an awful lot went on with those 10% most deprived communities and the elected members and those that had a say and were able to play a part in delivery onto those. And from that came the neighbourhood plan, as we've talked about before. There was a neighbourhood plan 6 years ago that directed the work of Stronger Together. We look at proof of the pudding is in the eating, isn't it? And they did a resident survey in the beginning, and they did one each and every single year as they went through the 4 years. Crime and safety came top of the list in the beginning, And it went from 40% of residents who answered the survey said it was a huge issue for them. They were scared of going out at nights, etc. In 2010, only 31% thought that crime was a big issue in their areas. Opportunities for young people, again, we changed people's perception by the work that was done. What I think is really interesting is health. In the beginning, nobody put health as an issue. They didn't think that the inequalities, that we didn't even realise the inequalities that existed, but they didn't think that access and them having a healthy lifestyle was an issue. We managed to change that by a lot of the work that we did. Education, nobody thought it was an issue. So education for their kids and the schools they went to wasn't a big thing. By the end of it, 1% of those sampled thought that it was. So in terms of what we actually physically did, there's a whole stream of work over the 4 years that made those perceptions much better at the end. There was a warden scheme, and just going back a second, there was this whole governance structure, but underneath that was the team, the neighbourhood team, and that was made up of a coordinator, a set of wardens, PCSOs, a whole stream. And the other key thing was they all worked together in one centre. So we brought staff together to share the issues, to learn from each other, to work with residents and to know who the people were they were working with. So a whole set of issues there. Opportunities for young people, junior warden scheme. We brought youngsters on board to take control and to become a bit more empowered about their communities and to get involved. Recycling proficiency classes, a whole range of actions that we took to get the youngsters involved. Improving health and wellbeing. My colleagues from Public Health will talk shortly about the Health Inequalities project that we led. But the first thing that we did was we had a massive big, or as we called it in 2007, a big breakfast, where we invited as many residents that wanted to come into the room and ask them what they thought the issues were with the health services and their health. And out of that came the Health Inequalities project, which we're going to talk about shortly. So from my perspective as lead for health, sat on that board, it was about reducing inequalities in health, reducing that gap. That's a little bit of what we did on education and skills. So we had job clubs. We worked with residents to upskill them and to get them access to decent jobs. Instead of jobs that just pay a menial wage, we tried to empower these people to think a bit broader. Parenting skills and budgeting, whole range. In terms of how we were assessed in 2002, it was a 4-year project. 1.6 million went into that project from government in 2006, a significant amount of money. We had 3 external assessments in 2010, one from the National Support Team for Health and Inequalities that came away saying, we believe that what you're doing is making a massive difference to your communities. And the tops, as we called it, the 100 top civil servants came down in 2010 and talked to lots and lots of residents, lots of partners who engaged in the programme to ask how it went. Again, they were very impressed, and I think the outcomes of that influenced further work that the new government have issued about neighbourhoods. One of the most fundamental pieces of work that was done was the London School of Economics came down because we wanted to look at the cost value of this. Has this changed impact on health services, on social services, on police, etc., etc. And unfortunately, when they started off in 2006, they never put a very clear evaluation framework in place, which is one of the things I would say. If you're going to start this from day one, you know where you want to go to and you know how to measure it. We didn't do that, but London School of Economics came in and they did some work, and it was a best guess. It was that. It was an estimate, but they put monetary values on some of the work that we'd done. Now, given that those residents live right next door to our local hospital and have been accused in the past of using it like a GP service because they sit next door to it, you know, we managed to change some of their thinking about usage of A&E. You can see there's £830,000 a year saved from those communities onto hospital services. And again, in terms of crime, 463,000. So they're significant amounts of money, and it's that money that we would hope to shift into services more locally. So where are we today? We learnt from the pilot and it was rolled out across Warrington. We've now got 5 or 4 neighbourhood teams. Some of them are light touch. On the most affluent areas, we have a very light touch. On the more deprived areas, it's more hands-on and it's more staff. More partners are now engaged in the activities because they see the benefit of this. Our health visitors work on a neighbourhood basis, so everybody's aligned to the neighbourhood. We are going through significant cuts in the council, and we are hoping that we can keep and retain neighbourhoods. It's not mandatory. That's the issue. If it was mandatory, we'd have a cat in hell's chance. It's not. So we are hoping to God that the good work and the outcomes will speak for themselves. So I'll pass on now to my colleagues in Public Health, Golden Gates.
So I'm Katie Donnelly, this is Count Kinsella. We're going to look a bit like a choir, but we promise not to sing. Well, you can, I'm not. Jan's given you a really good overview of some of the overall work that's going on in Warrington in terms of neighbourhood working, all the words that we've heard today, community assets, community development. What we're going to talk to you about specifically now is a project through one of the major housing providers in Warrington, through Golden Gates Housing Trust. So we're going to give you a bit of a story of that project, where it's come from, how it's developed, and Hazel's going to give you some real case study work, some specifics from the project and some feedback from local residents that have been involved in the project. So I won't labour on that. Jan's already give you a bit of an overview of Warrington and what Warrington is like. In terms of some of the lifestyle data, we've recently just done a lifestyle survey in Warrington, just literally getting the report through. This is probably not too dissimilar to a lot of the areas that all of you work in. One of the major thing, the starkest thing, is the whole inequality issue that Jan's already mentioned. And even now still, compared to the 2006 data, we're seeing still a real stark inequality difference. There's just some stats there. Social inequalities around mental health, emotional well-being, smoking prevalence, obesity, all the key ones that you probably see within the areas that you work in.
Okay, so Golden Gates Housing Trust, we're the biggest social housing provider in Warrington. We control about 70 to 80% of the stock. And as Jan was saying before, some of our housing is based in what's classed as the most deprived areas in Warrington, and that's about 65% of our total housing stock are based in areas where if you live in one postcode, you can live 10 years less than if you live in another. The landscape that we kind of operate in, we've got an ageing population, as I'm sure many of you have in the room. We've got about 29% of our customers who've got a disability. We've got an increase in the Eastern European population with low literacy and numeracy levels. We've got a high percentage of lesbian, gay and bisexual customers compared to the North West average. And we've also got issues surrounding things like the welfare benefit changes as well, which is a huge impact on our services and how we operate. Now, the vision for us is to be a leading housing provider, creating quality homes and neighbourhoods where people want to live. But how can we do that if we don't address the link between housing and health? We've got the aims to deliver the vision here as well. And as you can see, there's 6 aims there, and 4 out of the 6 can be linked into our health objectives. Especially something like improving the quality of life for customers, and also being a leader in energy efficiency. Things like fuel poverty have got a real impact on customers' lives, and now we've got public health and the health inequalities team who actually promote our energy efficiency services and the work that they're doing in the communities as well.
Okay, so that's a bit about Golden Gates itself. From the other partners, people that are key to this project are public health in Warrington, as in most areas. Public health, we've moved into the local authority now, and we're actually sitting within the Families and Wellbeing Directorate, which brings lots of positives in terms of wider determinants of health and embedding within departments within the local authority that may not have looked at public health before. So we've got lots of public health opportunities to move our work forward. Also, with us being in the Families Directorate, it gives us that life course approach and more influence across all divisions, really. We've then got the Neighbourhoods and Communities team that Jan's given a really good description of. One of the teams within the Neighbourhoods and Community teams is this Health Inequalities team that came out of the Stronger Together in Warrington work. Now, when I say Health Inequalities team, that makes it sound like it's an absolutely enormous team. It's 3 people, one of whom's currently on maternity leave. So we're not talking about a massive resource or a massive team. But what that team do is work and enable across a partnership approach, and and sort of capacity build, both across a community level as well as across organisations. What we've done within public health, working with partners, is developed a Healthy Lives, Healthy People plan, which is a plan not too dissimilar to lots of plans that you've heard about this morning, covering the wider determinants of health, focusing on the 20% most deprived areas, and looking across the partnership, how as a collective, with no additional resource, how are we truly going to address this health inequality issue and narrow that gap. I'll skip that. So in terms of this specific project, as Cam said, GGHT, Golden Gates Housing Trust, we'll refer to it as GGHT, are committed to the public health agenda. We were approached by the Chief Executive of Golden Gates Housing Trust to work with us from a public health point of view. As Cam said, GGHT have done loads of work improving the quality of the social housing stock, lots of regeneration work in specific areas.
Yeah. I mean, that's what we lead on. We are, strip everything back. We're a landlord, we're a housing organisation, but we understand the link between housing and health, and keeping people healthy in the properties means that at the end of the day we can actually keep our revenue there. We can get people staying in the properties for longer, which is keeping us running as an organisation. Obviously linking back into our vision, we want happy, healthy communities as well.
Yeah. So what happened at that stage was an agreement, and GGHT gave £40,000 to the public health team and the health inequalities team to do some specific targeted work with GGHT tenants and staff, which is where we then developed a GGHT health inequalities plan. We've got a number of clear objectives around that. The main ones for me really are to develop GGHT as a setting for health. This isn't just about one-off project work. It's about a mixture of strategic work as well as high visibility project work, but it's about embedding within an organisation and a culture a whole different way of working. So there's public health opportunities within every contact really that staff there make.
And that's internally and externally as well. We're training up our staff who've got a background in things like housing management or neighbourhood management, and we're training them to be able to spot indicators for things like basic mental health, suicide awareness training, as their financial distress increases with the things like welfare reform. These are integrally linked.
Yeah. In terms of monitoring, we have formal monitoring meetings, don't we, Cam, quarterly?
There's biscuits involved.
So we have like a monitoring framework that we complete that's like a quantitative framework that all the data, but we don't want to be too someone mentioned earlier, set by targets and that's all it's about. We have got a whole qualitative approach, that whole quality of life approach. What difference has this made to communities? What capacity building is being done? So it's not just solely about totally being target driven. It's a lot broader than that. We also have update meetings monthly, regular communication and contacts, really good working relationship across all organisations involved. So we have got a bit of a mini steering group and we try and feed into wider strategic groups. So for example, the Mental Health Partnership Board or the Older People's Board, to make sure the work's embedded within that broader structure really.
Yeah. And GGHT as a landscape's changed dramatically. We've got people in our organisation who now sit on the kind of alcohol partnership, dementia partnership, and also healthy eating. All of these different things that have an impact on health that we weren't necessarily involved in before, we're now using and reporting back to the relevant and feeding into the relevant partnerships as well.
Okay. So in terms of just trying to give you some sort of lessons learned from ourselves and some positives, and also we're going to go on to some challenges and opportunities. We'll talk faster. Obviously the commitment to work across organisations, we've already said, that difference of expertise, different agendas coming together into one place. The information sharing has been fabulous because GGHT have lots of information about their tenants. So if we want to target older people, for example, with winter warm messages or whatever the campaign can be, GGHT can run a search on their properties to see where we need to target. We've got direct access to people most at need in the communities where we want them, where we're addressing.
Which is always an efficient use of services as well. So it's obviously you can justify the money that you're spending because you're targeting the people most in need for the particular project.
Yeah. Obviously, it has got challenges and opportunities at all levels. That we, as Cam and I have already acknowledged, there are different priorities. We're here to improve health and look at lifestyle change.
We're a landlord.
So it's trying to bring the two agendas together across all levels within both organisations, working with staff to enable them and give them the skills to think about public health and public health opportunities within the work that they're doing in the day-to-day job. In terms of evidence in the work, there are issues around data collection specific to GGHT properties, because we could have a street within a deprived area that not all the houses on that street will be GGHT properties. So trying to do a postcode match won't work because we'd need the house number as well. So there are some technical difficulties like that. And one of the really important bits which GGHT have been great around is not to exclude non-GGHT tenants within a street. So if Fred that lives at number 4 isn't a GGHT tenant, that doesn't mean that we can't work with him. Really whizzing through really quickly so we can get on to Hazel. There's loads of different outcomes of the project. We've got a whole report that we've written together about what the outcomes we've achieved from the project, which we're happy to share with you. There's some specifics around the I-van, which is a cancer van, big yellow van, 23 foot, Hazel, that goes around the estates, gets people on there around like cancer screening. One of the key things there, 44 people, level 4 intervention needs to go to your GP quickly with a response within 2 weeks. So it is a way of picking up signs and symptoms that people might not have gone to the GP about.
And that's only in the last 12 months as well. So that's not over a long period of time, that's just 12 months.
There's loads of work that we've done on smoke-free homes. GGHT have done loads of door knocking, working with the health inequalities team. Got loads of people to sign up to the smoke-free homes agenda. Loads of different initiatives, some of which you've heard other people talk about today. I think as an overall, the outcomes that we've achieved and the tenants that would not have come on these groups and courses previously, we're getting them to come. So that in itself is really, really positive. Hazel is going to give you more specifics of one of the more innovative projects. Cam, I don't know whether you just want to give a brief about the process, Matt.
Can we actually, we'll move on to Hazel, and what we'll do is make sure that this is circulated. It's just that we're getting really behind time. But I want to give Hazel an opportunity because she's terrified and it's a challenge.
Hi, I'm Hazel. I'm one of the support workers that work on the health and equalities team, so I'm one of the 3 that... Oh, let's just click through. All I've got is pictures. I've got no other slides apart from pictures. This is so removed from my day job, it's untrue. I can't believe I'm actually standing here. So what the women's group is, this is a picture of the women group doing a Tai Chi session. It's a 10-week group where the women come along and they come to us 2 sessions a week, and we do a whole wide range of things with them. It's healthy eating, Zumba, Tai Chi. We go on walks. That's one of the ones they go on a walk. What it's about to try and inspire people to make behaviour changes through a combined focus of education and motivation. The education is done in a fun and vibrant manner as well. It's not like your normal education or anything like that. Anyone that's seen me do a healthy eating session, I can tell you I'm completely covered in the food that we're cooking. They know what we've cooked when I've got back to the office. It's also to try and increase the feelings of confidence and self-esteem in the women that come to these groups as well. A lot of the women that we've worked with, it's a normal day for them to get up, get the kids to school, they're still in their pyjamas, they go back to bed, they think that's okay and that's what life is, that's what their life is about. So it's about for us to say to them that, you know, there is other opportunities out there and to give them that confidence. It's also to introduce the women to a wide range of partners as well. So we have another about 12 to 15 partners that actually deliver on this group with us. We're kind of like the facilitators. We have the actual other people that come along and do the actual delivery. Because for us, a lot of the times for people try and access any lifestyle services or make any sort of changes to their well-being, it's a big barrier to meet a stranger. It's a huge barrier. So if they've met that stranger already in a group where they feel safe and comfortable, they're more likely to access that service afterwards. So some of the key things, I've just got some names here just to remind me who I was going to talk about. In one group in particular, one of the women said her family had actually started seeing them again. So basically she'd become isolated from her family and her friends because she lived in such a chaotic, depressive, negative cycle that they just didn't want to see her. So by her coming to this group, they actually started calling on her again and inviting her to family attendances and things like that, which you just can't explain that to somebody unless you've seen them go through that process of change. Another one, they cooked for their family for the first time, never cooked a meal at all for their children, and actually cooked a meal for them. But for me, this is one of the groups from Longford, what they wanted to do with the women themselves. They wanted to set up their own group that they could carry on meeting. So they've constituted with one of the community development officers, and they've also started recruiting other women that could come with them as well. They've all just gone through a 4-week voluntary training with the local voluntary centre, and this is them taking them to a green space which they wouldn't normally access with the kids. But they do that all themselves, they're getting the funding themselves and everything. But this is what I really wanted to talk about. In the Longford group, a girl came on the first session, a bit like me probably today, absolutely petrified with fear, and her only words were, "I'm here." That's all she said. Her family support worker couldn't believe that she turned up. Fast forward 10 weeks, she came to every session, might not have enjoyed every single session, but at the end of each group we run a celebration event where the women can invite their friends, family. We invite all the agencies that have delivered, and this girl actually, she wrote this herself and she read it to us in front of 30 odd people, to us as workers, to say this is what we've done for them.
Fantastic.
And that's it.
Okay.